Hey guys, it's Ahmed. I'm here to give you a follow-on to my ECG basics lecture, and I plan on including a lot more pathology in this particular one. So what I plan on covering is a lot of the arrhythmias, be that tachycardia or bradycardia, and I want to cover a bit about acute coronary syndromes and some of the stuff you'll see in electrolyte disturbances. So an arrhythmia is defined as an abnormality in cardiac rhythm. So you get quite a few different symptoms, and I've got a good mnemonic for it. Well, it's not a mnemonic really, but it's something I use to help me remember it. A lot of the times it can be asymptomatic though, so do bear that in mind. Classifying these, you can classify them broadly into tachycardic or bradycardic, depending on the beats per minute, under 60 or over 100. You can subdivide a tachycardia on where it arises in the heart, so be that supraventricular or not. So the first one I want to talk about would be atrial fibrillation, or AF for short. So this is an irregular and often rapid heartbeat, or arrhythmia, that occurs when both atria experience chaotic electrical signals. So what this means is that the atria themselves are receiving multiple reentrant electrical activity that causes them to try and contract simultaneously and a lot over a very short space of time. What this means for the heart is that it can't effectively pump blood from the atria to the ventricles. So it's not a good thing to happen. It's technically a supraventricular tachyarrhythmia, and it's characterized by uncoordinated atrial activity on your ECGs. You can classify them into paroxysmal, persistent, or permanent. This is dependent on the number of episodes of arrhythmia and how long they last, and if they're amenable to treatment. So paroxysmal would be recurrent episodes lasting more than 30 seconds, but they terminate within 7 days. Persistent would be lasting longer than 7 days, or anything that requires cardioversion, be that electrical or pharmacological. Permanent is not amenable to any form of pharmacological or electrical cardioversion and is accepted as a final rhythm. There are multiple different common causes to this condition. The classical causes, which you'd usually find in old textbooks, would be rheumatic heart disease and alcohol and hyperthyroidism. But a lot of rheumatic heart disease is on the decline. Well, it's very, very uncommon right now in UK. So it's not the first thing you'd want to say if your consultant or an examiner asks you, what are the conditions that cause AF? For those ones, you want to say something like hypertension, coronary artery disease, valvular heart disease, or heart failure. Other causes include hyperthyroidism, pneumonia, or some of the other respiratory causes like asthma or COPD, or lung cancer can also cause AF. So can diabetes and P. So here's an ECG strip showing atrial fibrillation. So if you ever get something like this, which I did in my OSCE, you want to look at the R waves, look at the intervals, and instantly see that they're irregular. You cannot see P waves. So the two big findings are absent P waves and an irregular rhythm. What this means is that there's no set pattern to its irregularity. So looking the R to R intervals between each QRS complexes, there'll be a varying number of squares between them, and there's no pattern between this. So what do you do from here? A lot of the times you want to be able to get a good CHAS-VASc score. So what this is a scoring system for your patient to see if they are more likely to need anticoagulation, because they're more susceptible to forming a clot. Think about it this way. These patients have aberrant electrical activity in their atrium. They're not adequately moving blood, so there's also turbulent blood flow. There's also more stasis. So these people are much more likely to form a clot. If they form a clot, you're much more likely to get a stroke and die, or get a PE and die. So you want to know when to give them coagulation or not. I think old NICE guidelines or old textbooks will say if someone gets a score of 1, you can give them aspirin, or if they have a score of 0, you can also give them aspirin, there's no harm. Well, now the medical evidence for that, or the new NICE guidelines, say that if they're 0 or 1, you don't have to give anything, or you can consider some sort of anticoagulation with a score of 1. A score of over 2 and over means that you want to be thinking about giving oral anticoagulation, in most cases warfarin. You also want to send away for blood samples for thyroid function, full blood count, liver function, because these are anemia, hyperthyroidism, and can both cause atrial fibrillation, you also want to check for any infectious causes. That's why you send away for an FBC. LFTs you're sending away for because you want to know if there's any coagulopathy. You want to see if this patient has a raised INR already, or if there's some sort of synthetic problem with the liver that would be contraindicated with anticoagulation, or if they need more anticoagulation to overcome it. You could also book an echocardiogram. Treatment is split into rate and rhythm control, plus or minus anticoagulation. Rhythm control is favored in the younger patient. Drugs like flecainide, sotalol, and amiodarone are your choices to go to. In patients who you choose rate control with, without any structural heart problems, your first line is a beta blocker or calcium channel blocker. Never give both of those at once. You can have great problems with blood pressure control if you do. Second line would be digoxin. If the person has a problem with their heart already, like a heart failure or structural abnormality, you can give digoxin as your first line and use amiodarone as a second line. The next thing I want to talk about is reentrant tachycardia. This is atrioventricular reentrant, or atrioventricular nodal, so the reentrant tachycardias. AVNRT and AVRT for short. These are common in younger patients. The first presentation usually occurs within under the age of 30 years. AVNRT occurs when there's two functionally and anatomically separate conduction pathways. These are usually fast or slow. So one being fast, one being slow. The AVN is getting electrical signals at a paced or spaced time between both. AVRT is an accessory pathway. It lies outside the AVN. This is what you see in Wolff-Parkinson-White. So these are the little thing that helps me remember the symptoms for most arrhythmias. So CPP, double D, double S. So chest pain, palpitations, dizziness, dyspnea, syncope, and sudden death. Here are some good ECGs taken from Kumar and Clark. So it shows you AVNRT and AVRT. Look for narrow complexes. P waves can be seen. Sometimes they can't be seen because they're eaten up by the QRS complex. Looking at the bottommost diagram, this one over here, you see the delta wave, indicative of a Wolff-Parkinson-White syndrome. That is the P wave being slurred into the QRS. Treatment-wise, you want to think about initially terminating the supraventricular tachycardia. It doesn't really matter if it's AVRT or AVNRT. The treatment will be the same for both in an acute setting. You want to start with a carotid sinus massage or a Valsalva maneuver. The thinking behind this is that you want to stimulate the carotid sinus bulb to initiate some more parasympathetic activity. Your second line, or if that doesn't work, you want to try adenosine. If you're giving adenosine to a patient, you want to make sure they are warned that it's very likely that they'll face some sort of impending sense of doom, or that the feeling that they're about to die is because they have a rapid reduction in their heart rate and blood pressure. It's very important to also reassure them that they are fine and you are there. After that, you can think about giving their beta blocker or a calcium channel blocker. You want to make sure that they maintain a normal sinus rhythm. A patient with Wolff-Parkinson-White, you want to think about giving an RF ablation. What this means is using radio frequency. You want to be able to cut off that accessory pathway and make sure they're not going to get another instance of it. So this is now AV block. This is a bradycardia. Heart block can happen in multiple different degrees. So it's first, second, and third. Second is also split into two separate subtypes. First degree is a PR elongation. It's just a set elongation. It can be due to a multiple number of causes that I would recommend learning about. These patients don't usually require any treatment. Second degree is split into type 1, type 2 from there on. So second degree type 1 is progressive PR elongation until there is a failure of a QRS complex to conduct. Second degree type 2, PR interval is either bordering long or is prolonged, but there is no progressive prolonging, so that means it's set, and all of a sudden there will be a drop in a QRS complex. This is the one where second degree type 2 is when you start treating them with an implantable cardiac device. Third degree is there's no relation between the P's and the QRS complexes, so P waves will be related to themselves, so the P to P interval will still be normal, and the R to R interval will still be with set. There won't be any irregularities there. However, there will be no coordination between P and QRS. So I'm now going to talk about some of the broad complex tachycardias. One of the most important would be ventricular tachycardia. It usually occurs due to a ventricular ectopic, and by definition there must be 3 or more extrastyles in successive rate, giving a heart rate of above 120 beats per minute. A lot of these patients will be in respiratory distress, and they might have reduced consciousness. VT can be monomorphic or polymorphic. What I mean by this is that in monomorphic, VT QRS complexes will be completely identical, whereas in polymorphic there'll be multiple different isoelectric lines. They'll be very wavy, and sometimes it can, in polymorphic, it's usually occurs due to QT elongation. For example, Tissot de Pointes is a example of a polymorphic VT. It's very important to note some of the drugs that can cause QT elongation. A lot of the the antipsychotics and the antidepressive drugs are known to cause QT elongation. So treatment-wise, you want to be thinking about DC shocking or giving IV amiodarone. Tissot de Pointes or polymorphic VT will require IV magnesium sulfate. So ventricular fibrillation usually goes down the ALS pathway. If you're at UCL, there is a clinical skill session about ALS pathway. It doesn't usually come up in OSCEs, however they do stay. That is very possible that they can give you a questions sheet about some of the causes or some of the things you should be doing in an ALS pathway. When do you give adrenaline? What should you do next? Which rhythms are shockable and non-shockable? So it's very important that you do read up on your ALS pathway. ACS stands for acute coronary syndromes. This can be either non-ST segment elevated or ST segment elevated myocardial infarctions. So in an NSTEMI, you're looking for ST segment depression and T-wave inversions. ST depression can usually happen either upsloping, downsloping, or horizontally. The most important ones to look for are horizontal or downsloping. However, upsloping is not usually specific to ischemia. T-wave inversions are very, very specific to ischemia. So here I'm showing you A being upsloping, B and C being downsloping and horizontal. So if you follow my pointer here, you can see that there are some T-wave inversions across a lot of the leads in this ECG. What I meant to show you in here is what you want to be on the lookout for in a left main stem occlusion. You're looking for widespread ST segment depression and elevation in lead AVR. So look at the elevation in AVR and widespread ST segment depression. So in a STEMI, you're looking for ST segment elevation in greater than 1 millimeter and pericardial leads or 2 adjacent limb leads. You can also diagnose STEMI with left bundle branch block. There is a very specific sequence to the ECG changes in a STEMI, and do learn how to diagnose a previous STEMI, which is usually very deep and wide Q wave. In my previous lecture, I showed you a nice diagram about the heart and its anatomical relation to the ECG leads. Well, this is another version of that, but on the ECG graph paper, you can see 2-3 in AVF for an inferior, for the inferior part of the heart, or seen in an inferior MI, and the blood vessel corresponding to it being the right coronary artery, the lateral being 1 AVL and V5, V6 being left circumflex, or a bit of the left anterior descending, V1, 2, 3, and 4 being anterior septal, and the main problem will be left anterior descending. So now I'm going to end off with a bit of the electrolyte disorders and what you most prominently will see. Sometimes they do ask about what you would see, or sometimes they'll show you an ECG and they'll ask you what's the main problem. So there's like specific little things that you should be able to pick up and say what the problem is. So in hyperkalemia, it's usually tall tented T waves. So look at the T waves, they're huge. So they're tall and they're tented. They look like mountains. That's how I remember it. Hypokalemia, I'll be honest, I've never really seen a question about ECG changes in hypokalemia. But what you usually see is a U wave, which is a wave after a T wave. The same goes for hypocalcemia. Usually they give you a lot of patient history behind it, but what you would see is a narrow QRS in a reduced PR interval or a long QT, maybe some U waves, but usually it's the signs that give it away. Calcemia, sorry. You can see tall peaked T waves, you can see wide QRSs or low R wave or loss of a P wave. But yeah, that's my lecture on ECG pathology. If you do have any questions, do email me. I think I'll put my email in the description. Thank you guys.